Yes, Sierra.
Sorry, mistake.
Oh, that's okay. All right. Do we have any sort of questions or anything we need to talk about before we get started with the study lab? No? Okay. So, the first thing we're going to talk about is fetal lie. So, that is how the baby is positioned in the uterus. This is super important. We always want to assess for this. As a nurse, you can assess for it when you do checks, but not super important that you assess for it because the doctor's going to. But you do it for yourself. So, the provider will be the one that will mainly do it, but you also can do it as well as you're assessing your patient during labor. So, like I said, fetal position or fetal lie is a position that the baby is in the uterus. You have transverse. So, this is when the baby is laying perpendicular with the mother's body. Oblique. This is when the baby is laying at an angle between transverse and longitudinal. When babies are in oblique position, they're very hard to birth because they're kind of crooked. Okay. So it's about nearly impossible unless you get them to turn to birth them in that position. And then, well, hang on just a second. My screen froze for a second. Hang on. Let me try to get this. There we go. Longitudinal. This is whenever the baby is laying parallel with the mother's body. So longitudinal, parallel with the mother's body. Transverse is when they're lying perpendicular, and then oblique is when they're lying at an angle between transverse and longitudinal. Longitudinal is the most easiest and common position. So this is the one that the babies usually prefer to be in, anyways. And then this is the easiest one to birth. So longitudinal is the easiest one to deliver. Okay. Now let's talk about like when we're monitoring contractions for our patient. So our onset is the exact time that the contraction begins. So it's 2:01 right now. If our patient started having a contraction, then that would be our onset of our contractions. Duration is the actual time the contraction lasts from the beginning of the contraction to the end of the contraction. Frequency is the time between contractions measured from the beginning of one to the beginning of the next. Intensity is the strength at the peak or acme. So that just means like the like strongest point of the contraction, right? So like when you have a contraction, it starts out you can start to feel your belly tightening a little bit. The mom's going to feel her uterus tighten a little bit down at her pelvic bone. And you're going to feel like it's going to get a little bit harder, a little bit harder, a little bit harder. And eventually it's going to reach the acme or the peak. And that is the strongest part of the contraction. Okay. That's how you palpate the intensity. So if you're palpating, you will tell your patient, tell me when you're beginning to have a contraction. And then you also watch on the monitor. When you see one starting, you go ahead and lay your hand on the top of the patient's fundus, and you're going to feel it, like I said, eventually start to get harder, 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 harder. And you can watch it on the screen. And when you notice that it's at the top of the little round hump, that's called the peak or the acme, that's when you want to palpate it and see, is it firm, is it moderate, or is it soft? And then it's going to start going back down to like ease off into the contraction. You also want to note the time that the contractions begin because your provider will ask you that. And then you also need to teach your patient how to teach or how to understand contraction frequency, especially if you have a patient who's at home and they're calling you and you're saying, okay, well, how far apart are your contractions? And if they don't know, you have to teach them how to time their contractions because there's a certain point you have to tell them to come in. So, onset is the time that the contractions begin. Duration is how long they last from beginning to end. Frequency is the time between contractions that is measured from the beginning of one to the beginning of the next. Intensity is the strength of the contraction at the peak or the acme. That's you palpating it to feel that. And then remember, we're teaching our patient that they're going to write down the time that their contractions begin and ends, and that's how they're going to tell you how far apart their contractions are. All right. So how do we know after the mom has had the baby that the placenta is separating? So signs of placental separation, your cord is going to lengthen. So honestly, you're not going to do anything with the cord. You're going to stand there and watch, but you still need to know this. Um, the provider will have the cord clamps on there and they'll sit there and just kind of hold it. And you can kind of watch after a certain period of time that cord's just gonna, they'll be able to like pull the clamps back towards themselves because that cord's gonna start to lengthen. The uterine shape is gonna become firmer and more round, and you're gonna see it move up the abdomen a little bit. And then you're also gonna have a gush of blood occurs. Whenever that happens, you know your placenta has fully separated, and the provider is going to help to kind of pull it out a little bit. As the patient, they might say, give a couple little pushes to help come out so they don't have to pull as hard. So, cord lengthening, uterine shape becomes firmer, more round, and you can kind of see that uterus move up the abdomen a little bit. And then also a gush of blood. Now, this is super important. Your gush of blood, whenever you are delivering your baby and you've delivered your baby, you're having your placenta delivered. That is normal. Gush of blood during that period is normal. It is supposed to stop and then it will do your normal postpartum bleeding. Anytime that you have any sort of big gush of blood after the placenta has been delivered, after you are already considered postpartum, then you need to worry about that, okay? All right. Group B strep. Remember, we said that's done between 35 and 37 weeks. It is the little swab that goes from the vagina down to the rectum. It determines if you have group B strep or not. If you do not have it, you do not have to worry about it. If you do have it, remember I told you that you can pass an infection to the baby that can cause them to be septic. They can become blind, all kinds of bad stuff, okay? So we have to treat them with penicillin G. They get 5 million units IV as a starter dose, and then they're going to get 2.5 million units every 4 hours. This happens whenever they are in the latent phase of labor, and it goes all the way up to delivery. So they'll have that all the way up until delivery if it's within the 4 hour mark for them to get it restarted.
What if the patient's allergic to penicillin?
I'm sorry, hang on, I can't hear you. What did you say?
What if the patient is allergic to penicillin?
There's different antibiotics they can have. Most of the time they'll do like Ancef or something like that. So that's a
Okay.
cephalosporin. And it is different. It's kind of the same family as penicillin, but it's a different class of medication. So they'll most of the time get Ancef or just like a different kind of antibiotic. Sometimes I've seen them give vancomycin for it. It just kind of depends on what your provider orders.
Okay, because I'm allergic to the entire penicillin family. So that's why I know there's some other people that are also allergic to the entire penicillin family.
Oh, okay. Yeah, sometimes they give vancomycin for it as well.
Okay, I just was wondering. Thank you.
Mm-hmm. All right. So Group B strep, remember we're treating that with penicillin. All right. So home births, birthing centers, and hospital births. So obviously your advantages of hospital births, they're safest for your high risk patients. You're going to have emergency staff and emergency equipment available at all times. You can have your pediatric provider present for delivery. This is the only place you can have a C-section. So you cannot have a C-section at home. You cannot have a C-section at a birthing center. And then you also have 24-hour around the clock support. So you have your nurses there, your pediatricians there, your providers are there. You have anesthesia there if you need to. All her hospital personnel is there if something were to happen. Disadvantages of this, some people find it intimidating. So they are just like really freaked out by hospitals. They don't want to go in there to have their baby. They think it's an intimidating environment. The woman's partner may be able to be less involved. This one, they're getting better with. Obviously, like a lot of the times, your provider or your partner's not going to be able to, like, be hands on right at your vagina, maneuvering things and catching the baby. But they are letting them be a little bit more involved. Like if they want to hold the leg, if they want to get down there to where they can see the process, and then, like, obviously cutting, clamping the cord, all that stuff. Um, so they're getting better with that. And then also birth plans. So this is a big thing. It says some may not agree with birth plans. That's a disadvantage. So, as a labor and delivery nurse, if your patient brings in a birth plan, you must adhere to that if it is safe for the patient and the baby, and it does not put um, the rest of the facility in harm. So, like if your patient comes in and says, I don't want to give my baby a bath the entire time they're here, that's safe. We would have to, adhere to that. It's their baby, right? It's their birth plan. If they come in and say, I don't know, I'm trying to think. Um, Shoot, I just drew a blank in my head. Anyways, anything that, like, if they come in and they say they want to have like these hot plates set up in the room and all this stuff, that doesn't have the correct electrical cord that is supposed to be used within a hospital facility. We can't do that because it's putting the rest of the facility at danger. We can say we would be more than happy to set up these hot plates or whatever for you once we have the correct cord that complies with hospital policy. But you have to make sure, like I said, that it's not putting the mom, the baby, or the rest of the facility at harm. So birthing plans, that's kind of a disadvantage that they feel sometimes the hospital doesn't agree with them. And then also noisy and not much rest. And then a birthing center. So these are dedicated to labor and delivery care only. So it's kind of like a hospital in a sense, but it's only for labor and delivery. They encourage the patient to make their own decisions. You can invite family and friends to participate in the process. And then most birthing centers are affiliated with a hospital. So if something were to happen during the birthing process, they could easily transfer you over to the hospital. Disadvantages, they have a very rigid screening criteria. So they're going to ask you, I mean, every single thing that you can think of, because high risk moms are not allowed to have their babies in birthing centers. Um, they also cannot manage complications from your pregnancy. So if you do have your baby at a birthing center and let's say that you have some sort of a shoulder dystocia and they cannot get it unlocked and you have to go down for a C-section, they cannot do that. So you're going to have to be transferred mid shoulder dystocia to the hospital, which we know when we have a shoulder dystocia, time is of the essence. Um, so there's that. And then also, you don't have a pediatrician present at birth. It's just the people who work in the birthing center. Home births, people feel like the advantages are they're able to relax more and they have more privacy. They have one-on-one care, whether that be a home birth midwife or maybe they have a doula, or they don't have anybody. They just have their partner or a supportive person, someone else. Um, they also have labor progressing without interventions. So I feel like that's one of the biggest reasons that people want to do a home birth. They don't have to have interventions. They don't have to have the checks. They don't have to have the Pitocin. They don't have to have the IV fluids, the IV, which you can still request that at the hospital. You can tell them that you do not want checks. You can tell them that you do not want Pitocin, and they have to respect that. The only thing they can do is if it's like a life saving event, let's say the patient's hemorrhaging and you're trying to give them Pitocin at the hospital, and they deny it, then you have to say these are the risks of you not getting this. You could die, and then obviously if they say no, you have to respect the patient's wishes. But and then also they feel like with home births, bonding is enhanced, so they're not having to be separated from their baby as much. Hospitals have gotten better with this. You have your baby friendly hospitals where they leave the baby in the room with the mom and dad as much as possible, on the mom's chest as much as possible. So they're getting better with that as well. And then disadvantages for home birth, you have no medical help at all. You have no access to any sorts of equipment. You have no access to the OR if something were to happen that are bad. You also have no pain medications at all. You have to be transferred to a hospital. Like somebody will have to either drive you there or an ambulance will have to come and get you if you have an emergency. And then home deliveries are 10 times more likely to result in an APGAR score of 0. A lot of people choose home births, each their own. I absolutely cannot stand them. Every patient that I've ever had that has had a home birth has came in like a train wreck, whether it be the newborns being a train wreck or the patient's bleeding out train wreck. So I don't like them, but like I said, to each their own, and obviously everyone has to make their own decisions about things. All right. So another thing you need to know with that is, could you all be able to pick out a patient who would be like a candidate for a home birth or a birthing center if you were given a list of patients based off of what we just talked about? One person says yes. Anybody else? Okay, perfect. So basically, the people who can have home births or birthing centers are people who have absolutely nothing wrong with them. So they have a healthy pregnancy, right? No complications. All right. Pain medication during labor. We know that we can have an epidural, right? Which is the most common. We also know that there are different types of medications that you can have IV. One being Stadol. This is something that they give for moms who are don't want an epidural or they're not quite ready for their epidural. They'll give them Stadol IV to kind of help short duration, but it does help a little bit. If you have a patient who does not have an IV, or I'm sorry, does not have an epidural, and they request pain medication, whether it's fentanyl or Stadol or something like that, and let's say that they're like 8 centimeters, are we going to give that to them? No. Too close to delivery, yeah, because what would happen to the baby? I can't hear you. I'm sorry. Well, it will do overdose like tendencies. So anytime you give a narcotic that close to delivery, the baby cannot have it metabolized for it as well. So it doesn't like go through the mom, the placenta, all that stuff, and metabolize before it hits the baby. So it can cause respiratory depression. So the baby could come out either not breathing at birth or come out with like agonal gasps at birth, and then you're going to have to do resuscitation on your baby. So no IV pain medication when their delivery is imminent. So pretty much from like teetering between 7 to 8 centimeters on. Okay. Amniotomy. Everybody knows what that is? Hopefully.
And I'm gonna take them out that way.
What? What? Okay. Amniotomy is whenever you are having the amni hook and the provider is rupturing your membrane, so your water. There are a couple things that you have to know whenever you are assisting with an amniotomy procedure. So first off, you're going to get your provider's sterile gloves laid out for them. You'll have some jelly out there for them. Amni hooks are also sterile, so you're going to let the provider put on their gloves first, and then you will open the amni hook in a sterile way. So you're just going to pull the paper apart and let the provider grab it himself or herself. You don't touch it. You have to have your patient on the monitor before they have an amniotomy. They cannot be off of the monitor. This is because, think about it, a baby swimming in a nice big pool in there. They're getting ready to get that pool popped and drained. Sometimes that can cause them to be really stunned. and it can cause some decelerations. Sometimes it can even cause some really bad decelerations. So you have to be on the monitor so you can make sure you're monitoring that. And then also, anytime that you are doing an amniotomy, you have a risk of a cord prolapse. Obviously, if the cord comes all the way out, you're going to see it. You're going to know you're having a cord prolapse. But there also will be signs from the monitor as well if it does not come all the way out. So the baby will have very, very abrupt deceleration and it will not recover and it will not come back up. So your patient has to be on the monitor when you're having an amniotomy. You also have to you also have to note the time that the water was broken, the amount of the fluid. So, was it a small, moderate, or large amount of fluid? The color of the fluid, was it clear? Was it meconium stained? Was it clear with a little bit of pinky tinge to it? Does it have an odor? So you will know if it has an odor. You don't have to get down there and smell it. Just if you don't smell anything when you're standing up there, then you're good. And then you also have to make sure that you are monitoring heart tones for 1 full minute after an amniotomy and stay at the bedside with your patient. You do not leave. Stay at the bedside with your patient and monitor for 1 full minute after an amniotomy to make sure that your baby is not going to have a deceleration. Everybody good with that? Okay. APGAR scoring. So when do you do APGARs?
1 and 5 minutes after birth.
Yep. And let's say that you have at 5 minutes an APGAR of 4. What do you do? I'm sorry, let me rephrase that. Not like what do you do, like how do you fix it, but when would you take the next APGAR? Do you guys know? That's okay. So you take it at 1 minute of life, 5 minutes of life, and you want the score to be at least a 7 or above. If it is at 5 minutes below 7, then you will take an APGAR every 5 minutes up to 20 minutes of life. Okay. So if you have a baby that has been born, it's 5 minutes old, and the APGAR is 6, then you would take the next APGAR at 10 minutes of life. Does that make sense? Perfect. So that's about all with that, okay? So every 5 minutes after the 5 minute mark if it's below 7. And then if you take another APGAR after that and it's 8, then you don't have to worry about doing it every 5 minutes, okay? All right. So you have a patient who has just had their baby. You as the nurse are going to assess a couple things, obviously. What would you think your number one priority would be to assess with the mom immediately after she has had her baby? Anybody?
Vital signs?
Well, those are important, but your very, very first thing that you need to assess after your mom has had the baby is vaginal bleeding and fundal firmness. So, obviously, our vital signs, if she's okay, are going to be staying steady, right? They are important, but they're not as important as vaginal bleeding and fundal firmness. After we have a mom who's immediately had a baby, we know right afterwards is like a big time period where they could hemorrhage if they're going to. So we always need to inspect very well and make sure that we have an okay amount of vaginal bleeding, because they are going to bleed some, but it's not super, super heavy. And when you're looking, they didn't really teach us this in nursing school. This is just like somebody who's done it for a while, and I'm telling you this. When you're looking at your patient, if they're like kind of laying back a little bit, always make sure that you're looking under their bottom too. If they can help you raise up, let them do it. If not, you need to kind of roll them to their side and check under their bottom, because the way that they lay in the bed after they have a baby, sometimes that blood can kind of pull and seep under their butt, and you're looking at them and you're like, oh my gosh, you don't really have that much bleeding. You're fine. Yeah, Just kidding. It's all under their bottom, and they probably are at that point hemorrhaging. So make sure you're checking and rolling your patient to ensure that you don't have any blood pulled up under their bottom. And then you also want to make sure that their fundus is firm in midline. So if their fundus is firm and it's midline, then you are probably okay. You're probably not going to have any sort of hemorrhaging going on at this moment. But those are the two most important things in the immediate postpartum period that you need to check for: vaginal bleeding and fundal firmness. All right, different types of monitoring. So we have intermittent monitoring and then continuous monitoring. Intermittent is like whenever somebody has an uncomplicated pregnancy, so they have absolutely nothing going on with them. They're not anemic, they're not diabetic, they have nothing going on with them. This is, you can do this for someone when they first come in to start laboring. You'll put them on the monitor, you'll put the straps on them, and you'll get a 20-minute NST. As long as the baby passes the NST, you can take the monitors off. They can walk around, do whatever they want to do. And then you will come back intermittently and monitor them. So you'll put them back on, you'll get another fetal heart tone, you'll get another contraction pattern, see what all's going on, and just kind of like periodically check on the baby. Now, once their water ruptures or they get an epidural or anything like that, then they have to go to continuous monitoring. Continuous monitoring is wearing them all the time. So those stipulations they have to do. And then also if you're a high risk person, so you have any sort of anything going on with you, hypertension, preterm labor, post-term patients. So if they are past 40 weeks, they have to be on the monitor all the time, because at that point you're worried about placental insufficiency or your placenta giving out because it's old, right? It's past the due date. Maternal cardiac disease, oligohydramnios or polyhydramnios, so too much or too little fluid. Multiple gestation, so they have twins, triplets, anything like that. An induction of labor. So if they're coming in for an induction and they're having Pitocin, they absolutely have to be on the monitor. There's no question about that. If they say no, then you say you're not getting Pitocin, because you cannot have a patient with Pitocin and not have them on the monitor. Administration of an epidural, like I said. So if they have an epidural, they also have to be on the monitor, just because epidurals have a tendency sometimes to make moms hypotensive. And if mom gets hypotensive, we know baby reacts from that. So baby may crash, and we have to be able to see that. Any sort of VBAC. So if you're trying to have a vaginal birth after a C-section, so if your previous baby was delivered a C-section, and now you're trying to have this one vaginally, you have to be on the monitor. And that is because VBACs have a high tendency for uterine rupture. And then also diabetes. So I would be able to pick out what type of client that you could have either continuous monitoring for, or that you could monitor intermittently. Okay. Everybody okay with that, or do we want to go back over those one more time? Yeah. Did you mean to do that, Chelsea, or are you accident? Okay. Let's see. So decelerations, well, first let's start with accelerations. So accelerations is an increase in the fetal heart rate that is above the baseline. So your baseline is kind of what your baby stays at for a quite long period of time. And then your accelerations are going to be these big increases in the heart rate. That's at least 15 beats per minute. And then it'll go back down to normal, to the baseline. Those are fine. You don't have to worry about them. They're great. Decelerations, some you have to worry about, some you don't. So a deceleration is whatever your baby's baseline heart rate is, it's going to have a decrease in that, okay? Episodic decelerations are not associated with contractions. So if you guys are did you look at the contraction strips in the book? Because when I explain this, if you've not looked at them, you're not going to understand this probably. Has everybody looked at those? Yeah. Okay. So sometimes when you look at the top part, which is the baby's heart rate, and you look at the bottom part, which is your contraction period, if you have a decel in the baby's heart rate at the same exact time that you're having a contraction, those are called periodic decelerations. It happens like your period, right? Like it's supposed to happen at the same time all the time. If they do not happen at the same time as a contraction, then they're called episodic. So they've just happened. It's an episode. We don't know why that it's happened really, but it just has. Early decelerations. These are the only decelerations that you do not care about. If they happen, you're yaying because that means we are having head compression, we're having adequate contractions, and we're hopefully getting closer to having a baby, right? So early decelerations are caused by head compression. They are not dangerous. We are happy to have them. We do not have to do anything to them. Late decelerations. These are the ones you have to worry about, especially if they become prolonged. So late decelerations are caused by maternal hypotension, uterine hyperactivity. So if we have more than 5 contractions in 10 minutes, we become tachysystole, and that's uterine hyperactivity. Late decelerations are also caused by placental insufficiency. So, if our placenta is not perfusing correctly, the baby's not getting enough oxygen and the baby is becoming hypoxic. So, it's causing them to have a decrease in their heart rate. Late decelerations come after the contraction. So, if you're looking on your contraction strip and you're seeing a contraction start out, it's getting up all the way to the peak, it's starting to go down, and then finally your uterine tone is back to normal, then you're going to start seeing your baby having a decel in the heart rate. And you'll see the contraction on the strip, and then afterwards you'll see the decel. And this is because your baby has been compressed from the contraction. And one of those things that we just talked about is going on, and the baby is not getting reoxygenated properly for some reason. That's why it's having a decel in the heart rate. Variable decelerations. These are abrupt decreases in the heart rate of 15 beats or more, and they're usually sharp. So usually they look like a V. They come straight down and they usually kind of come straight back up. Sometimes they can look like a U. Sometimes they can look like a W. So sometimes baby says, oh my gosh, what's going on? Dip in the heart rate. I'm going to recover a little bit. Oh my gosh, just kidding. Back down. And then it's going to recover a little bit. Okay. Those are usually caused by cord compression. So it can be from how the baby is laying during a contraction and it's compressing on the cord itself, or it can be from how the cord is laying itself too. And then when you have a contraction, based on how the mom is positioned, she can compress the cord. So everybody good with decelerations? What is the type that we don't care about? We like to see. Early, right? Okay. True labor versus false labor. So, true labor, your contractions are going to come at regular intervals. So, it may start out, you may have a contraction, and then 15 minutes later, you have another one. And then 25 minutes later, you have another one. And then within an hour of you doing that, maybe you start noticing, okay, they're every 10 minutes. And then another hour after that, you're like, okay, they're every like 6 to 8 minutes. They're coming at regular intervals. So that would be true labor. With true labor, the contractions also become more intense as labor progresses. So they may not start out hurting really bad, but once you're realizing you're in labor, they're going to start hurting pretty bad. They increase in duration over time. So you may have a contraction for like 5 or 10 seconds, and then eventually you're going to have it for like 30 to 60 seconds, up to 90 seconds. Okay. Discomfort with true labor is going to begin in your back, and then it's going to radiate around the front of the belly down to the pelvis. Sometimes you can even feel it in the vagina. And then also, if you're in true labor, you're going to start to have effacement and dilation. Your contractions intensify with walking, and they do not go away when you sit down and rest or take a warm shower. Now, if you're having false labor, your contractions are not regular, so they just stay like 1 minute, 5 minute, 37 minutes, like just they're random. They do not increase in duration. They do not cause dilation. And then if you sit down and rest or you take a warm shower, they're going to stop. And they also do not intensify with walking. So I would know the difference between true and false labor. You also have charts in your book for this next section that I'm going to talk about. It tells you how to manage a deceleration, like variable, early, or well, early don't do anything, but variable or late deceleration. I would look at those. So one in particular, especially I would check out, would be for variable decelerations. For the medical management side, your provider's gonna tell you to administer a tocolytic for a variable deceleration. They also may ask you to do an amnio infusion. So an amnio infusion is where you're going to have an IUPC, which is a cord that goes inside of the vagina, kind of up against the uterine wall in the baby, and it measures your contractions. So you're able to tell how exactly strong the contractions are from the inside versus the outside. On this little IUPC, there is like a port, like an IV port almost. You're going to hook up normal saline to that, and it's going to be room temperature, and that's going to infuse, kind of like put water back into the uterus. And what this is doing is, we know variable decelerations are caused from some sort of cord compression, right? So this is putting more volume into the uterus, kind of inflating it a little bit more and taking pressure off of the cord, so we do not have any more variable decelerations. You also, for your nursing considerations, if you have somebody who has a variable decel, are going to change the position to decrease cord compression. So if they're on the left side, you're noticing you're having variable decels, then you're going to flip them to the right side. Or if they're sitting up in a throne position, you're going to get them back out of that, lay them back a little bit, and kind of elevate their feet. If you have a patient who's on Pitocin and you're seeing these, then if your uterine activity is like really hyperactive, so you're having that tachysystole point where you're having more than 5 contractions in a 10-minute span, we're going to either get a provider's order to discontinue the Pitocin, or we will decrease it a little bit. You can also give the patient oxygen by a face mask at 10 liters per minute. You're going to assess maternal hydration. So maybe you give your patient a little bit of bolus of fluids as well through their IV. Also notify your provider if you see variable decelerations that are recurrent. Your provider may ask to do an FSE, which is a fetal scalp electrode. It is a little hook that screws into the baby's scalp, and we get an accurate fetal monitoring, like a heart rate for the baby, versus on the outside as well. And then also be sure to provide support to your patient. So be supportive, be very educational, tell them what's going on, tell them what you're doing, explain everything, because they're going to be very appreciative of that. So look at that chart in your book that talks about variable decelerations and the medical management nursing interventions. Okay. All right. Preterm labor risk factors. So if you have a patient who has no prenatal care, or they are late to prenatal care, they're at risk for preterm labor. This is because, number one, we don't really know how far along they are. We don't know past medical history. We don't know current medical history. We don't know if they have anything complicating the pregnancy. If they have a history of preterm birth before, maternal age younger than 17 or older than 35, any sort of domestic violence survivor could have preterm labor. Placenta abruption, over distension of the uterus. So this can be either from polyhydramnios or multiple gestations. So if you're having twin pregnancies, triplets, whatever. incompetent cervix. So if your cervix is already dilating pretty early and starting to disintegrate, then you're probably going to have preterm labor. Cervical inflammation due to bacterial vaginosis or trichomonia, any sort of torch infection or UTI because of the inflammation, hormonal changes or fetal stress. If they're having inadequate placental perfusion, hypertension, diabetes, smoking or substance use, and then also if they have a short cervix that's less than 25 millimeters, that all puts them at risk for preterm labor. So if you have a patient, be able to pick out, if they gave you a list, what would be a risk for preterm labor and what would not. All right. And then if we have that patient who's at risk for preterm labor and they come into the hospital and they're getting checked out and they think they do have they're starting labor, we do what is called a fetal fibronectin on them. So fetal fibronectin is a protein that helps the amniotic sac adhere to the uterine wall. If they are going into preterm labor, it's usually detected around 22 weeks to right at 37 weeks. If the protein is detected, then it's probably going to indicate they're in preterm labor. If it is not detected, then delivery is not imminent. So fetal fibronectin is that test that you do to test for the fetal fibronectin protein. If it is positive, then they are going into labor. If it is not, then they are not going into labor. All right, you need to know the signs and symptoms of magnesium toxicity. So remember, we give, most of the time we give mag sulfate for someone who has preeclampsia or full-on eclampsia. Remember that a big side effect for magnesium is respiratory depression and then diminished reflexes. So if you see a patient and they have a respiratory rate of like 12 or 10, and let's hope it doesn't get below that, but if it starts getting lower and then you notice that their reflexes are starting to be diminished, then you're going to think that they are becoming toxic to the mag. And remember, the antidote for mag sulfate is calcium gluconate. So anytime you have a patient who's on magnesium, you always want calcium gluconate at the bedside. This is because it is very critical that you give it immediately when you see that they're becoming toxic, and you do not want to have to rush back to the Pyxis or Acudose or whatever you have to pull it out. And most of the time, it's going to be dispensed with the bag of mag sulfate. Calcium gluconate is going to be rubber banded around the bag, and you're also going to have instructions rubber banded to the bag as well. And it's going to tell you how to give it, what to assess for, and then obviously it'll tell you like a little tidbit of the calcium gluconate, like that it's the antidote or whatever. So mag sulfate toxicity, you want to worry about respiratory depression and diminished reflexes. All right. If you have a patient who comes in and they're talking about, I'm not really sure if my water's broke, or maybe I've peed on myself, maybe I'm sweating a little bit. There are a couple of different ways that you can to check for this. So the first one is called a amnisure. So this is like the swab that you'd actually put in the vagina and swab around. You have to send that down to the lab and they'll run it. Do that one first for sure. But then there's also like a little test that you can do. Most units just keep this on stock to be have it available to be handy. It's called nitrazine paper. It looks like a little post-it note, like a long thin post-it note. You just rip it off and you can either rub it directly like on the vagina where the fluid is, or the pad. If you have them on a pad and they have it a little bit in there, you can rub it on that. This is a quick and easy way to determine if the water is being broken. If it is amniotic fluid, it's supposed to turn like a really dark blue or a dark purple. And that kind of lets you know, like, yeah, your test is probably going to come back positive. Nitrazine paper cannot definitively diagnose if someone's water has broken, but it's something that is quick, that you could do quickly. Okay. Chorioamnionitis. So, speaking of our water being broken, anytime that we have a rupture of membranes, we have a chance for infection. That infection, because we have an entryway, right? Like our membranes are ruptured, and that's an inlet for infection. Chorioamnionitis is whenever you do get infection after your membranes have been ruptured. This can lead to sepsis and it can lead to death if it is not treated. So they will get antibiotics during labor, they will get antibiotics after labor just to make sure that we eradicate that infection. This is something you'll know if your patient has it because it has a very, very foul odor. So that's why it's important when you have an amniotomy, so they've ruptured the membranes, that you're checking and making sure that your patient does not have an odor with their fluid that's coming out. Signs and symptoms of chorio are a fever greater than 100.4, maternal tachycardia that's greater than 120, fetal tachycardia that's greater than 160, the purulent or foul smelling amniotic fluid. Uterine tenderness is also a big one. So this is like the patient to where you're going to easily palpate on their abdomen and they're going to come out of the bed. It's going to hurt, okay, because they have an infection and inflammation going on in there. And then also, once you see all these other signs, your provider's probably going to order some lab work and their white blood cell count is going to be high, so over 15,000. All right, 7 P's of labor. You have passage. So this is the route that the fetus moves through to be delivered. Passenger. This is the baby itself. So it's the passenger, right? We're trying to get it out. These can be affected by the lie of the fetus, the presentation. So is the head presenting? Is the butt presenting? The feet? What's the presenting part? The attitude of the fetus as well. Your powers are your contraction. So they have to be powerful, right, to get the baby out. Position. So there's a position that mom is in can also help facilitate labor. If mom's just trying to labor from one side to the other and it's not working, then maybe we're going to do some spinning babies. We're going to put a peanut ball under her leg. We're going to set her up in throne position. So she's sitting straight up like she's sitting in a chair with her feet dropped down. You're going to drop the bed and drop her feet, and that's going to put more pressure on the cervix. So different type of positioning. And then psych. So this one is really super important. First, we have to make sure that our mom's prepared to give birth. So we want her to be educated. We want her to feel confident. We want her to feel safe and secure. So all those factors need to tie in together so that she is mentally sound to have this baby and trusts you to do it. You also have to evaluate the psych portion for people who have any sort of like sexual trauma. So I know we talked about this before, domestic violence, the last study lab. If we have someone who has either been raped or any sort of sexual trauma but has not been completely raped, they may have psych issues during delivery. So we talked about they may not want to do vaginal exams. They may not want to be exposed as much. Super important that we assess that with our patient. And like I said, if they have this, they've told you, hey, I've been raped before, you need to say, are you okay with doing a vaginal exam? And if they say yes, then you would like narrate everything. I'm getting my gloves on. I'm putting some lubricant on. Can you please spread your legs? You're going to feel me touch right here. It may be a little bit cold. I'm going to be gentle. Okay, I'm touching now. Like literally narrate everything you're doing for these patients. So psych is a very, very big thing that you would look for in a patient if they've been like sexually abused or had any sort of trauma or anything like that. Yes.
Can you name the 7 P's off again real quick, please?
Yeah. Passage, passenger, powers, position, and then psych. Got them? Okay. Let's say that we have a patient. They come in. they're laboring, and then all of a sudden they are like, oh my gosh, my water just broke, and now they have a cord prolapse. Can we have that baby vaginally?
No.
No. We cannot have that baby vaginally. That is not safe. The cord's going to be compressed. The baby is not going to get any oxygen. There's a risk for infection. If you have a cord prolapse, it is a medical emergency. Get your butt in gear, call the provider, call anesthesia, go down to the OR. You're having a C section, always. There is no maybe possibility. You're going to the OR. If you have a cord compression, it is also important that you know what to do, okay? So you're going to place 2 fingers into the vagina, and you're going to elevate, like if the baby has a thigh on it or a butt on it or something, you're going to elevate whatever presenting part that you feel off of the cord. When you do this, your hand's not coming out of there till you go to the OR. So you best get on the bed with the patient, keep your hand in there, keep it elevated off of the cord. You're going to place your patient in a knee to chest position, so Trendelenburg position, and that's going to also help to kind of alleviate presenting parts off of the cord. If the cord actually comes full out of the body, you're going to cover it with a wet gauze and place it into the vagina. Now, this don't mean wet it under the sink, right? We're going to get some sterile water and put it on there, and place the cord back into the vagina. You're going to give mom oxygen via face mask. And like I said, prepare for birth. So this is when you're going to really rely on your coworkers, and you're going to push the emergency button, and you're going to holler for your coworkers and tell them, you call the provider, you call the OR team, get the stuff I need for the patient. Let's wheel me down to the OR, because you're staying on the bed with the patient and keeping your fingers in their vagina. Okay. And you're not having your baby vaginally. You're going down for a C-section. Okay. Another medical emergency that could happen with delivery is shoulder dystocia. So, if your provider is calling shoulder dystocia, what you're going to do is called a McRoberts maneuver. You're going to lay the mom back all the way pretty much flat. You're going to hyperflex the mom's thighs to her abdomen, and you're going to kind of keep them spread out a little bit far. So, kind of like a butterfly almost, not as dramatic, like half butterfly. And then push them back against her abdomen. That's McRoberts maneuver. That's the first line treatment for a shoulder dystocia. If he's able to deliver the baby, perfect, we're done. If not, sometimes they will have you add on. It's called suprapubic pressure with McRoberts maneuver. So you're going to get right to the pelvic bone, and you're almost like doing like a, trying to think, like almost like you're doing CPR, like you would do that kind of a motion. You're not going to push that hard, but you will push to help facilitate the baby on out. But you do not do that unless your provider asks you to do it. You're going to just do McRoberts maneuver first for a shoulder dystocia. That's your first line intervention. Okay. Another huge thing that you watch for whenever you have a patient who has delivered is uterine inversion. So this is also something that is life-threatening, and it's an obstetrical emergency. Uterine inversion is a complication that can lead to hemorrhage and shock, and the patient can also die. So you have an acute inversion. This happens within 24 hours. And then you have a subacute inversion. So this can happen within the 24-hour mark, but before the 30th day postpartum. So signs of this are postpartum hemorrhage. So they're going to start bleeding profusely. A mass that comes out of the vagina, kind of like, you know, those squeezy stress balls that like pop up. That's kind of what it would look like coming out of the vagina. And then signs of shock. So your patient's heart rate's going to skyrocket. The blood pressure is going to bottom out. All the signs of shock. So uterine inversion, if you see this and you are treating a postpartum client on the floor, you immediately call your provider, okay? You do not do anything else until you call that provider, because they have to be there to fix the issue. All right. while we're on the list of emergencies, amniotic fluid embolism used to be super rare. You really never seen that. And then for some reason, in the last little bit, it's become a lot more prevalent. I feel like you see it a lot more these days than you used to. So, amniotic fluid embolism is basically like your body is having a reaction to you having the baby. Okay. So, what happens is something happens to where amniotic fluid or fetal debris or something like that gets into the mom's circulatory system. And the body is like, hey, what is going on? This is not supposed to be here. It's foreign. And then you have an anaphylactic reaction, basically. Okay. Um, this can be as severe as the mom like going into cardiac arrest and dying. This is something that has to be recognized immediately and it has to be treated fast because the longer that you do not recognize it and do not treat it, the worst percentage that your patient is going to have in recovering. So this is like top dog emergency here. Your signs and symptoms are going to be dyspnea, and your patient, like, what is so weird about it is they'll tell you, like, I'm really having trouble breathing and I just really feel like something bad's going to happen. Like, I just feel like I'm going to die. And then you'll start noticing they become severely hypotensive. They're going to have an altered mental status. They may have a seizure. They may have pulmonary edema, severe hemorrhaging, uterine atony that does not respond to a massage. And then they go into cardiac arrest. And then if you don't treat it, they're going to probably pass away. So amniotic fluid embolism, super, super bad. Have to recognize it immediately. And it comes from amniotic fluid or fetal debris that comes into the mom's circulatory system. Hang on just a second. Hey, listen, mommy's doing something. Can you go back in here for just a second? I know, I'm sorry. Sorry. My sister and my nephew are here and they're playing with my kids and apparently they're fighting over a toy. All right. Fetal demise. So if you have a patient who has either had a demise while they're laboring and it was unexpected, or if they know that they've had a demise and they're coming in to deliver the baby, this is something that you really have to handle with a lot of care because it is just all around a terrible situation. Okay. So when you have a patient come in for this, you're going to treat them as if, it's a normal labor. You're still going to be empathetic and sympathetic towards them. You are going to still explain everything to them because they're still going through the laboring process. They may still have to have Pitocin. They're still going to get an epidural. They're still going to get all the things. So you would educate them just as if you would for a patient who is having a normal delivery. You also want to allow them to have as much like interaction as possible. So once the baby is born, you do everything like you normally would. You would get footprints of the baby. You get pictures of the baby if they ask you to. Obviously, allow them to hold it, encourage them to hold it. Don't force it if they don't want to, but encourage them to hold it. You would still clean the baby. So you'd give it like a little bath and clean it off, but you have to be really careful sometimes, especially if it's an early demise because the skin can peel off. So you have to be super careful with that. You can dress the baby. So if they have clothes they would like to put on the baby, you can do that or ask them if they would like to dress the baby themselves. If not, I know a lot of hospitals now are doing perinatal grief programs. So the hospital that I used to work at, they had a program where it was called angel dresses. And then for the little boys, they just had like kind of like a little like shirt made where they would bring in stuff for, especially for demise parents. So you would dress the baby in that if the mom and dad were okay with it. And then they also had like little necklaces for the mom that had whatever month like birthstone it was for the baby. So allow them to do that and be a part of all of that. Encourage healthy expression of grief. So if they want to talk about it, sit and talk to them about it. Um, if they are interested in support groups, you would definitely try to find them information on that and refer them to that. And then always encourage them if they feel like they need to get their mental health evaluated to get a mental health evaluation or go to therapy or something like that. Okay. All right. Circling back to amniotomy, I know we've already talked about this a little bit, but there are certain clients that you are allowed to have an amniotomy with, and then those that you are not. Did you guys look at that in your book?
Would you mind to talk a little bit more about it?
Yeah. So when you do an amniotomy, your patient has to be basically what's called engaged. So you have your pelvic bone. And then the baby, when it is not engaged, is called like free floating or blottable. So you can reach up into the vagina when you're doing a check and like push the baby's head and it's going to float up into the uterus, right? If it's engaged, its head is well down in that pelvic bone and it's not coming back out. Those patients you can do an amniotomy on. Anytime the patient is well engaged and the head is the presenting part, that's the perfect candidate to do an amniotomy. So to rupture their membranes with an amni hook. If you have a person who is not engaged, so the baby's head's not way down in the pelvis, or you have a different presenting part other than the head, like if they're breached or something like that, they're not a candidate for amniotomy. This is because they are at risk for cord prolapse. So that's why it's super careful that you're doing checks, your doctor's doing checks, you're understanding what you're feeling. So you're making sure it's a head and you're making sure that the baby's engaged. Okay. If it is not engaged, it is not a head. So if it's a butt in the breech position, feet that you're feeling, they're at risk for a cord prolapse. Does that make sense? So basically, if you're given a list of patients and you know that the patient is not engaged and you know that the head is not the presenting part, then those patients would not be a candidate for amniotomy. Okay. Vacuum extraction. So sometimes this is something that happens. Your provider may have to help the baby come out a little bit. They may put the little kiwi on their head to help them come out. When they do that, they'll put it on there. You, as a nurse, are going to watch the contraction. You're going to tell your patient when you're having a contraction, and then you're going to say, okay, we're having a contraction now. Can you please push with the contraction? As they're pushing, the physician is also going to pull and help the baby come out a little bit more. So if you have a person who's using the vacuum extraction, you want to just educate them. This is your contraction. Please push now. And then the provider's going to pull as they're pushing. We talked about VBACs or TOLAC. So VBAC is vaginal birth after C-section. TOLAC is trial of labor after C-section. So we don't necessarily know what's going to happen with a TOLAC. We're going to try it to see if they can labor and have it vaginally. If not, then we'll just go down to the OR and have a C-section. So the biggest complication that you need to remember with a TOLAC and a VBAC are uterine ruptures. Okay. All right. We talked about true and false labor already. We talked about how you give calcium gluconate for magnesium toxicity. All right. This one we haven't talked about yet, but it goes along with preterm labor. So, if you have a patient who's in preterm labor and it's imminent, so we've done the fetal fibronectin, it's positive, we know that they're going into preterm labor. Um, we want to make sure that we are giving a steroid right to the baby because we want to make sure that we're helping the baby get some lung development. Hopefully, we can stop labor. If not, at least we're getting a steroid on board so that the baby can have a little bit more lung maturity and have a little bit easier time if delivery is imminent, transitioning to extrauterine life. So, steroid, betamethasone usually, but any sort of steroid they give. Okay. All right. So if you had a patient who is having intermittent monitoring, they meet the criteria for it, and you are going in their room because they say they need to go pee, and you're helping them up. And as you're walking to the bathroom with them, they said, "Oh my God, my water just broke." What would you think would be a priority assessment for you? Would it be to get them on the monitor immediately and check the fetal heart rate or assess the color of the amniotic fluid? Now think about this before you answer. Priority.
You'd assess the amniotic fluid.
So that you do that, but that's not the priority. So remember when we talked about, yes, it's important to know the color of the amniotic fluid, but what did we say could happen with a patient who has had their water rupture? What's the baby at risk for? Decelerations, right? Amniotic fluid, that color is not going to change and it's not going to do anything for us. If the baby's having a deceleration and we don't know it and it's not recovered, baby can die, right? So I understand why you think the color of the amniotic fluid is important, and it is. You can look at it, but you're going to take your patient back to the bed, you're going to put them on the monitor, and you're going to assess your fetal heart tone, and then you can note the color of the amniotic fluid. Because right there in that moment, is your patient going to die over the color of the amniotic fluid, or if their heart rate is in the 60s for the baby? The heart rate, right? Does that make sense? Okay, perfect. Now, if it was like a controlled situation and they were already on the monitor and in the bed and the water broke, then you could be like, okay, I see your fetal heart rate. You're good. Now I'm going to focus on the amniotic fluid. All right. Anytime you have a patient who's on oxytocin or pitocin, remember their contractions are usually going to be anywhere from like 30 to 60 seconds. We do not want them longer than 90 seconds because they are going to end up having that uterine tachysystole, which is more than 5 contractions in a 10-minute period, or just like a really big prolonged contraction. And then that can lead to baby not getting adequate oxygenation. So we always want to make sure that we report to the provider if the patient has a contraction that's lasting longer than 90 seconds, because we may have to do like some pitocin titration. With epidurals, so we're always checking vital signs before to make sure that the patient is stable. You will also check the platelet count to make sure that the patient is stable before they have an epidural. Usually before the anesthesiologist comes up to give the epidural, you're going to give your patient a bolus of fluid. Most of the time it's just a little 500 ml bolus of lactated ringers. You're doing this because you do not want the mom to become hypotensive whenever they are getting an epidural. And that is a very, very common side effect, just because of where it is placed, and also because they're laying kind of a little bit more flatter than they normally are. So administer fluid boluses before an epidural, okay, to prevent hypotension. And then also at any point during the immediate time after an epidural, um, if they become hypotensive, there is a medicine that anesthesia will give them. But you, as the nurse, can also give them a little bit of a fluid bolus as well. Remember, I know we've already hit this a little bit, but if we have a patient who has variable decelerations, remember we talked about we can give the tocolytic or we can do the amnio infusion. We've talked a little bit about intermittent auscultation. We want to do that every 15 to 30 minutes. Okay, so we always want to keep a good check on our baby. The first initial time they're on it, they have to have a full 20-minute strip to make sure everything looks good. And then after that, you do every 15 to 30 minutes. You just can kind of intermittently check on the baby. All right. Remember, anytime that we have any sort of deceleration that's not an early deceleration, there are like nursing considerations that we can do. So we can turn the patient. That's always your first thing that you'll do when you see a deceleration, because we don't know if it is from cord compression or what's going on. So we're going to run in. If the patient's on the left, we'll turn them to the right. If they're on the right, we'll turn them to the left, and reposition. See if that fixes the deceleration. If not, then you can go on down the list. Give them a bolus. You can maybe give them an amnio infusion, start oxygen, and then eventually, if it's in the order for you to decrease the pit, you can. If not, you would get an order to decrease pit. But first thing you can do that's not invasive is turn your patient if you have a deceleration. All right, a BPP, which is a biophysical profile. This is a test that you do, especially after an NST. So let's say that a patient's having an NST and they didn't pass it. So the baby didn't pass the NST. They do the BPP, the biophysical profile. It's kind of like a well-being check on the baby. So they want to see, is the baby actually okay? And what this is like a big ultrasound, and it's going to measure things like how many times the baby moves within a certain period of time, how many times the baby breathes within a certain time period. This just lets us know that the baby's okay. So a BPP score of 8 to 10 is normal, and that indicates a low risk for fetal asphyxia. So the baby's getting oxygenated well. We're not worried about it not being oxygenated. So 8 to 10 is your normal range for a BPP. And those are done after an NST if the baby did not pass the NST. So an NST, which is your non-stress test that we just talked about, to consider passing that, they have to have 2 accelerations. So that is the going above the baseline of what it normally is for 15 beats, lasting at least 15 seconds. Okay. So 2 accelerations of 15 beats per minute above the baseline for at least 15 seconds within 20 minutes. That's a reactive NST. That's good. That's what we want. All right, contraction stress tests. So sometimes these are done to see, like if you have somebody who has kind of like a complicated pregnancy, and they really are having issues and they probably need to be delivered, but you're kind of wanting to test the waters first. These are done to see how the baby is going to respond to labor. Are they going to tolerate it fine and keep vital signs normal, or are they going to have decelerations? Okay. So for a negative contraction stress test, this is going to be no late decelerations, with 3 contractions in 10 minutes. That's what you want. So you want the baby to be able to have contractions, not have any late decelerations, not have any perfusion issues, and to just, chug right along and be fine. So you want a negative contraction stress test. No late decelerations with 3 contractions in 10 minutes. All right. And then remember with your quad marker screening that we've talked about before, the estradiol level, or I'm sorry, hang on. Let me read my notes just a second. So the quad marker screening, they have those 3 levels that you have to know. That are with an increased risk of Down syndrome. So you're going to have the high HCG, the high inhibin A, and a low estradiol. Okay. So 2 high and 1 low, and the estradiol is the low one. And those are an indicative of Down syndrome. Okay. That's all I have. Everybody feel okay? Yeah. Any questions on anything? Nope. Okay. Well, if you guys feel okay, then we'll go ahead and hop